Hello everyone, welcome to ENT Mastery course. I'm Dr. Mehak and in this video we'll be talking about vestibular neuritis. So I'll be covering this topic under following headings. First we'll talk about the introduction, then pathoetiology, clinical features, clinical examination, diagnosis, recovery and resolution, management and treatment, then prognosis, and then the differential diagnosis. Okay, so let's start this presentation. So coming to the introduction, vestibular neuritis is probably the third most common cause of peripheral vertigo after BPPV and Meniere's disease, and among patients presenting to the OPD of vertigo and dizziness, vestibular neuritis accounts for around 8.1% of the diagnosis. This is as per Sataloff. Now, in the adult population around, and this is as per the 8th Scott Brown 8th edition, these two lines are as per Sataloff. And in the adult population, around 40% of all dizziness has been caused by peripheral pathology, which includes the vestibular end organs of the inner ear and or vestibular nerve. And of these peripheral pathologies, 2 to 23% have been reported to be due to vestibular neuritis. So as per Scott Brown 8th edition, it is 2 to 23%, and as per Sataloff, it is 8.1%. Now, vestibular neuritis is an acute inflammatory disorder of vestibular nerve characterized by vertigo, nausea, and vomiting. And even though vestibular neuritis is preferred nomenclature, labyrinthitis is more commonly used among laymen and also medical professionals. However, if used strictly, labyrinthitis includes cochlear pathology that has hearing loss and tinnitus in addition to vestibular symptoms, and other terms such as acute idiopathic peripheral vestibular dysfunction and vestibulopathy are occasionally also used. Now, there is no difference in gender prevalence in vestibular neuritis, and the typical age of presentation is around 40 to 50 years old. And although it is present in pediatric population, it is much less common, with a suggested prevalence of around 1.8% in children presenting with vertigo. Now, talking about the pathoetiology, so the selective inflammation of vestibular nerve is the most favorable etiology, and the inflammation of the nerve can cause demyelination and associated loss of function, which can be irreversible. And the temporal bone studies have shown evidence of chronic inflammatory changes of the vestibular nerve with diffuse perivascular lymphocytic infiltrates consistent with post-infectious inflammatory changes. Now, so basically inflammation is the problem with the vestibular nerve that has been confirmed with temporal bone studies also. And there is indirect evidence of inflammation of vestibular nerve, but not of inflammation of vestibular neurons. So it is nerve that gets affected and not the neurons. That is why we don't use the term vestibular neuronitis. We call it vestibular neuritis. Now, vestibular neuritis may have viral cause, which is supported in some patients by history of preceding and coinciding cold or flu, or epidemics of cases at a workplace or among family members. However, this is not a prerequisite for the diagnosis. Then reactivation of latent virus has been suggested, and the presence of HSV1 DNA in human vestibular ganglia and nuclei has been shown. Also, co-localization of latent HSV1 and CD8 plus T cells in vestibular ganglia further supports the hypothesis that HSV1 reactivation is possible and may cause vestibular neuritis. Other human Now, although HSV1 is the most favorable viral agent, there is evidence that several other human viruses can cause isolated peripheral vestibular dysfunction, including rubella, cytomegalovirus, Epstein-Barr virus, adenovirus, and certain strains of influenza types A and B. And Borrelia infection has been noted in some instances, that is as per Cummings. Now, the evidence, so the Evidence of viral infection being the etiology remains indirect and circumstantial, and other etiologies of acute vestibular loss are certainly possible, such as surgical unilateral vestibular deafferentation, that is vestibular neurectomy. Then head trauma may cause acute vestibular loss, and immunological cause have also been suggested. And in patients with vascular disease, particularly the elderly, a vascular etiology seems likely, but it is very rarely proved. Then comes the clinical features. So coming to the clinical features, so vestibular neuritis presents with symptoms and clinical signs related to sudden isolated unilateral vestibular loss. Then symptoms typically consist of sudden onset of persistent vertigo, that is commonly a subjective sensation of rotation with associated distressing autonomic symptoms such as nausea, vomiting, sweating and pallor. Symptoms will worsen with change in position and head movements. The severely affected patients will not be able to walk unsupported but will prefer to lie down on their side, often lying on their affected ear. And will, with milder cases, the patient feel dizzy and imbalanced with some nausea, but they may not feel unwell enough to render seeking medical advice. Then severe symptoms would normally last for a few days before gradually starting to spontaneously resolve. Then balance related complaints, particularly caused and or related to rapid head movements, may be present for months after resolution of acute disease. Then BPPV occurs subsequently in smaller percentage of patients. There should be no associated cochlear symptoms like hearing loss and tinnitus, neurological symptoms or signs of brainstem lesions. Now, when sudden sensory neural hearing loss accompanies vertigo with a vestibular neuritis like pattern, classification as a sudden sensory neural hearing loss ought to be considered. So, basically, whenever there is a component of sensory neural hearing loss along with the vertigo, you have to rule out sudden sensory neural hearing loss, because there in vestibular neuritis there won't be any hearing loss. Okay, and in this regard, the treatment appropriate for sudden sensory neural hearing loss should be instituted, and evaluation should include evaluation of retrocochlear lesions like acoustic neuroma. Then basically, if we talk about which nerve gets infected more in vestibular neuritis, then it is superior vestibular nerve. So there are two branches of vestibular nerve, that is superior and inferior. Superior nerve is more commonly affected in vestibular neuritis, which may be explained by its course through a longer and more narrow bony canal, making it susceptible to swelling causing entrapment. Now, accordingly, only approximately 18% of vestibular neuritis affects the inferior nerve. That is as per Scott Brown 8th edition. Now, the presentation of symptoms, clinical findings, and the results of vestibular testing will depend on which branch of vestibular nerve, that is the part of vestibular system, is affected. So superior vestibular neuritis presents with vestibular lesion that affects the anterior and horizontal semicircular canals and utricular function, but spares the posterior semicircular canal function and most of the saccular function. And in contrast, inferior vestibular neuritis affects the posterior semicircular canal function and saccular function. And although vestibular neuritis is mostly unilateral, bilateral sequential involvement has been reported. Now basically, if we talk about this, there is one more theory that says is the canal of superior vestibular nerve is longer and has more speculae, whereas posterior semicircular canal is innervated by additional anastomosis. So that is why the posterior semicircular canal, that is supplied by inferior nerve, is less affected. Now this difference may explain why posterior canal is often spared. Okay, and why other canals are affected. Now, so the visual vertigo, dizziness provoked by visual environment with repetitive or moving visual patterns, is common with peripheral vestibular dysfunction. For this reason, the patients will dislike visually busy environments such as traffic, crowd, and supermarket aisles, which will induce dizziness, imbalance, and sensation of disorientation. Now, BPPV is common sequelae to vestibular neuritis and will develop in the affected ear in 10 to 15% of cases. That is as per Scott Brown 8th edition. Now, even though, so that this is the next line, that since the posterior semicircular canal remains functional, patient often develop BPPV as a sequelae even though they have no remaining horizontal and anterior semicircular canal function. So that is what, because posterior semicircular canal does not get affected, that is why patients get BPPV as a sequelae, because it is normal and there is something that can affect posterior semicircular canal. Now, anxiety disorders and panic episodes are very common in association with vertigo and imbalance, and it is likely that in some patients, vestibular dysfunction may play an important role in etiology of these disorders, and often anxiety and panic episodes may be the main presenting symptoms associated with vestibular neuritis. Now, there is something called as diagnostic criteria of vestibular neuritis that has been suggested by Coates, and it is also called as modified Coates criteria. So, this consists of acute onset of non-recurrent vertigo that is often accompanied by nausea and vomiting. Absence of cochlear symptoms, that is what, hearing loss and tinnitus will not be a sign or signs of central nervous involvement. That will be, you have to rule out, if these symptoms are present, then you have to rule out other things, that we'll talk about these things in differential diagnosis. Then commonly unilateral, partial or complete peripheral vestibular lesion, and complete subsidence of symptoms within 6 months. So here basically in this diagnostic criteria, first two are mainly symptoms. Then the third is like when you make a diagnosis. So most of the time vestibular neuritis will be unilateral only. So it is commonly unilateral, partial or complete peripheral vestibular lesion. And third, the last point is like recovery, like the prognosis, complete subsidence of symptoms within 6 months. Then the most common characteristic clinical finding with sudden unilateral loss of vestibular function is the spontaneous peripheral vestibular nystagmus. That is suggestive of the vestibular neuritis. Okay, so this is the most characteristic clinical findings. So in acute loss of peripheral vestibular function, results of slow vestibular induced drift of eyes in the same direction as the lesion. Okay, so the nystagmus will be in the same direction as the lesion, and the drift is interrupted with the rapid saccadic eye movements in the opposite direction. So this combination of slow and fast eye movements, the slow component will be towards the side of the lesion and the fast eye movement will be towards the opposite side. So this combination of slow and fast eye movements constitute the spontaneous peripheral vestibular nystagmus. Okay, so that will be towards the normal side. Okay, the fast component that we call as nystagmus will be towards the healthy side. So the nystagmus is horizontal with the torsional component. Its direction is defined by the fast phase and it is described as the first, second and third degree nystagmus. So in acute severe cases, the nystagmus is initially present with optic fixation, but in milder cases and during recovery, there will be no visible nystagmus with optic fixation. And okay, now when only inferior vestibular nerve is affected, spontaneous nystagmus is rare. It is only important to note that the other types and directions of nystagmus, that is purely torsional, vertical and disconjugate nystagmus, indicate a central pathology and should prompt further investigations. Then comes the clinical examination. So horizontal, torsional, spontaneous nystagmus, beating away from the side of the lesion, more vigorous without optic fixation. Okay, this is how it will be, the nystagmus. So head thrust test will be positive on the same side as the lesion. Okay, these 3-4 points are important here. So these first 2 points are very much suggestive of peripheral vestibular lesion. Okay, and the gait test and Urtenberger test show deviation to the side of the lesion. Romberg's test show marked increase of sway. Then comes the diagnosis. So these testing facilities are only available at specialist centers and consist of caloric, VNG, ENG, C and O WEMP, subjective visual vertical and horizontal, and video head impulse test. So the caloric is a gold standard for diagnosing unilateral peripheral dysfunction with a reduced or absent response on the affected site. And the VNG ENG recordings of eye movements allow a more detailed evaluation compared to clinical examination, in addition to providing record of eye movements. And the rotatory chair that is used in combination with VNG or ENG is a gold standard for diagnosis of bilateral vestibular loss. And the standard test battery. So what is standard test battery? So basically standard test battery can also identify peripheral vestibular asymmetry. So this means that the standard vestibular test battery is used to detect peripheral vestibular asymmetry. That means that one side of vestibular symptoms is functioning differently from the other, and this standard test battery can include caloric testing, rotatory chair testing, video head impulse or WEMP. Okay, now so the O WEMP and C WEMP can determine which branch is affected in an episode of vestibular neuritis, that is superior or inferior vestibular nerve. So that way we can use O WEMP and C WEMP. Okay, and in most of the cases O WEMP will be affected because the superior vestibular nerve is the one that gets affected the most. Okay, so O WEMP is for superior and C WEMP is for inferior vestibular nerve. Then the video head impulse test. So I spoke about head impulse test, that the head thrust test is positive on the same side of the as the lesion. So similarly is the video head impulse test is relatively new development, and it has been suggested that the video recording of head impulse test improves the sensitivity of this test. So an abnormal video head impulse test has been shown to be associated with vestibular loss in more than 62.5% identified with caloric test. Okay, so that means this is as per a study. Just remember that video head impulse test is more sensitive compared to the caloric tests. Then a routine otologic examination is usually unremarkable, and CT scanning of the temporal bone reveals only normal appearing bony labyrinth. But if we talk about the MRI, that may occasionally indicate some inflammation. Okay, so occasionally the eighth nerve on or membranous labyrinth will be enhanced after contrast on MRI, but this only indicates inflammation of unknown cause. And serologic studies can demonstrate that a virus infected that a virus infected the patient, but they do not prove that infectious agent caused by inner ear damage. Furthermore, isolation of infectious agents from the nasopharynx or other tissue other than the membranous labyrinth does not prove a causal relationship between virus and the inner ear disease. Now, although a few viruses have been cultured directly from perilymph samples in the infected ear, this is not a practical method for routine diagnosis of viral infections of inner ear. So serological tests are basically not to rule out virus infections are not necessary here. So then is about the recovery and resolution. So like we saw in that Coates criteria, that symptoms will subside in 6 months. Okay, so the majority of the patients with vestibular neuritis recover fully without intervention within 6 to 12 weeks. This process may be partly related to restoration of peripheral vestibular function and partly to the development of vestibular compensatory mechanism, which involve brainstem, cerebellar, cortical and spinal functions. Now, the recovery does not follow a linear pattern, but symptoms will often fluctuate. However, a ground rule is that reoccurring symptoms will not be as severe as symptoms appearing during initial vestibular insult. Now, if we talk about the the vertigo is experienced when there is an asymmetric resting activity between two vestibular nuclei. And neural recordings in animals recovering from a unilateral peripheral vestibular lesion show that central compensation depends on an increased spontaneous neural activity in the ipsilesional vestibular nucleus and a decreased spontaneous neural activity in contralesional nucleus, thereby rebalancing activity of the left and right vestibular nuclei. Now, so patients who are able to compensate fully for the vestibular loss will mostly remain asymptomatic and unaware they are balancing using mainly 1 year rather than 2. They feel subjective back to normal. And elderly, and in some patients, especially the elderly patients, those who with additional CNS disorders, the compensation will not be as effective, or it will be lesser. Now, this will lead to chronic peripheral vestibular dysfunction with persistent sensation of imbalance. So, in older patient, this acute thing becomes chronic, and there will be persistent imbalance, and even recurrent episodes of decompensation can be there with recurrent episodes of imbalance. So, complaints about sensation of floating, rocking, and lightheadedness can be there. Then recurrence rate of vestibular neuritis is very low and may involve the other side. And patients would typically have one episode of sudden onset of vertigo, and any recurrent episode that occur could be explained by episodes of temporary decompensation. However, with recurrent symptoms, other etiologies must be considered, such as migrainous vertigo, BPPV, and Meniere's disease. Now, talking about the management. So basically management is, so symptomatic treatment is the management. Okay, there is no role of surgery, there is no role of giving antiemetics or something for a long time. For lesser duration you can give, but not for a long time. So symptomatic treatment with antiemetic medications during the acute stage is often required, and antihistamines, anticholinergic agents, and dopaminergic agents are most commonly used drugs. Then fluid replacement is necessary, particularly in severe cases. And most antiemetics are vestibular sedatives and will suppress the stimulus of sensory mismatch, which is required for habituation and compensation. Now, it is therefore important that they are only used during the acute stage, since prolonged use has been shown to prevent the development of vestibular compensation. So remember that you have to use it during the acute or symptomatic stage, like acute stage only. You can't keep using it, because then the compensation will be affected. Then accordingly, regular vestibular sedatives are not indicated in patients with chronic dizziness and should preferably not be given for longer than 3 days, following which they should be used only as an emergency medications on an as and when required basis. So also vestibular neuritis may cause adverse effects on quality of life, affecting activities such as driving, employment, and loss of confidence in everyday living. An important part of management is to advise the patient clearly of the benign nature of the condition and to reassure patients with their symptoms that their symptoms will settle. Also inform patients of the fluctuant nature of the recovery process and common prevalence of decompensation. Advice on safety is important and may be required with regards to driving workplace and increased risk of falls. And there is at present no clear consciousness or consensus with regards to specific treatment for vestibular neuritis, and benefit treatment with oral corticoids in acute stage has been suggested. So oral corticoids are useful, whereas antivirals are not useful. So despite the suggested possible of viral etiology of vestibular neuritis, no benefit of antiviral treatment in acute stage has been shown. Then rehabilitation exercises are safe and effective treatment for unilateral vestibular dysfunction and is required in some patients to enable recovery and development of effective compensation. And CNS needs stimulus of sense, so the central nervous system needs the stimulus of sensory mismatch for habituation and compensation, and control studies have indicated that vestibular exercises can accelerate balance recovery and development of compensatory mechanism. Now, whether more frequent exercise leads to faster recovery, that is not known. Now, vestibular rehabilitation should be started when the acute stage of nausea and vomiting is past. So that is important. You shouldn't tell vestibular rehabilitation exercises when the patient is in acute stage. Now, it is thought that vestibular compensation develops more quickly and more effectively if the patient is active as soon as possible. And vestibular rehabilitation exercises are like Cawthorne-Coxie exercises as well as gait retraining exercises. Then we have cognitive behavioral therapy. So we have seen the underlying cause of the vestibular neuritis can be anxiety and panic disorder. So in those cases, cognitive behavioral therapy is also useful. There is no role of surgical management, but as per some studies, like surgical management can be done for persistent symptoms. So why it is thought that the indications for surgeries are not clear, and it is presumed that persisting labyrinthine asymmetry as a result of neural degeneration is responsible for ongoing symptoms of vertigo and disequilibrium. And there is not a reliable method for determining what symptoms are due to labyrinthine dysfunction and which are due to incomplete central compensation. So the results of vestibular neurectomy for vestibular neuritis are less favorable than Meniere's disease, and persisting labyrinthine dysfunction is more likely. Then comes the prognosis. So basically when we are talking about the surgery, we are talking about vestibular neurectomy, but it has no role and it is less favorable. Why we do for vestibular neurectomy? Because we saw in pathoetiology that the constant inflammation can cause degeneration, and that's why vestibular neurectomy can be helpful. So anyways, now the prognosis. So basically vestibular neuritis is a benign self-limited disease that has a good prognosis, and the general rule is complete recovery of balance with resolution of disequilibrium after variable amount of time. And patient may show persisting sensitivity to rapid head movements towards the affected side if vestibular function does not recover. And recurrence of vertigo may occur in 2 to 11% of patients, although it usually is less intense than during the initial attack. And secondary BPPV may develop in up to 15% of patients with vestibular neuritis, and it is treated with particle repositioning maneuvers. Then differential diagnosis. So dysfunction or lesions in brainstem and or cerebellum can cause something called as vestibular pseudoneuritis, as well as other peripheral vestibular disorders may mimic vestibular neuritis. So talking about the central lesions mimicking vestibular neuritis. So what happens is the lesion that occurs in a small area at the lateral medulla, including the root entry zone of vestibular nerve and the medial and superior vestibular nuclei, they may be confused with lesions of peripheral vestibular nerve or labyrinths. Okay, so patients with multiple sclerosis who have pontomedullary plaques or small lacunar ischemia or infarction in the territory of anterior inferior cerebral artery at the root of entry zone of 8th nerve. So this can lead to fascicular nerve lesion which mimics vestibular neuritis, and that is called as vestibular pseudoneuritis. And a small lacunar infarction of vestibular nuclei or dorsolateral pons may also mimic vestibular neuritis. Now, the differential diagnosis between central and peripheral cause is easy, because if the patient has when there is obvious additional brainstem sign, but if brainstem signs are not there, then differential diagnosis becomes difficult. Therefore, in several studies, the clinical signs to differentiate vestibular neuritis from central vestibular pseudoneuritis in the acute situation were correlated, and the final diagnosis was assessed by neuroimaging. And none of the isolated signs are reliable, like head impulse test, saccadic pursuit, gaze evoked nystagmus, or subjective visual vertical. None of them are reliable. But as per some studies, there are two exceptions, that in most studies, skew deviation. What is skew deviation? That is a test for vertical misalignment. So if there is a skew deviation, vertical misalignment in the eyes, okay, so if there is skew deviation or normal head impulse test in patients with acute onset of vertigo and nystagmus was a specific but non-sensitive sign of vestibular pseudoneuritis. That means if skew deviation is present and head impulse test is normal, that means there might be a central component. So a combination of different clinical signs, for example, skew deviation, head impulse test, gaze holding function, fixation versus peripheral vestibular spontaneous nystagmus, all these things together, however, can increase sensitivity and specificity to more than 90%, but there is no single isolated sign. Then cerebellar infarction may also mimic vestibular neuritis if it occurs in territory of posterior inferior cerebral artery. An infarction in the territory of anterior inferior cerebral artery may also mimic vestibular neuritis, but it is most often associated with anterior inferior cerebral artery unilateral hearing. If anterior inferior cerebral artery is there, then there will be unilateral hearing loss due to cochlear ischemia and additional brainstem signs. Then acute attacks of vestibular migraine may also mimic vestibular neuritis because they may be associated with rotatory vertigo and horizontal torsional nystagmus, and accompanying symptoms and the course of the disease help to differentiate between these two entities. Then comes the peripheral vestibular lesion. So the differential diagnosis of peripheral labyrinthine and vestibular nerve disorder mimicking vestibular neuritis includes numerous rare conditions. Now, apart from that, extensive lab examination, lumbar puncture, CT, MRI are not a part of routine diagnosis for vestibular neuritis because of two reasons: because of rareness of these disorder and typical additional signs and symptoms indicative of other disorders. So an initial monosymptomatic vertigo attack in Meniere's disease or a short attack of vestibular paroxysmia can be confused with uh, vestibular neuritis in patients admitted to hospital in acute stage. And but the shortness of attack, that is in Meniere's disease, and the rapid recovery, however, allowed differentiation. And during the course of disease, almost all the patients with Meniere's disease develop tinnitus, hypoacusis and tinnitus and oral fullness in the affected ear, which is not seen in vestibular neuritis. Tinnitus and hearing loss is not there. Okay, so that is how you differentiate. And also if we talk about Ramsay-Hunt syndrome, so an initially burning pain and blister as well as hearing disorder and facial paralysis are typical in herpes zoster oticus or Ramsay-Hunt syndrome. And in these cases, acyclovir and valacyclovir will be indicated. And also there can be skew deviation in herpes zoster oticus because there is complete unilateral peripheral vestibular deficit, that is both superior and inferior parts of vestibular nerves are involved. Then we have the Cogan syndrome. It is a severe autoimmune disease that is accompanied by interstitial keratitis and audiovestibular symptoms, that is hearing disorders are very prominent here, and it occurs mostly in young adults and respond in and they have good response to corticosteroids, high dose corticosteroids, like any other autoimmune disease, and you give other immunosuppressive agents also here. Then the rare variants of vestibular neuritis have been described. Example, inferior vestibular neuritis, where there is a selective deficit of posterior semicircular canal combines with sparing of lateral and anterior canals, and a form in which the dysfunction of posterior canal is combined with one of the cochlea. Now the later probably does not have viral etiology, but vascular etiology is there since both these structures have common area of vascular supply. So here in inferior vestibular neuritis, the etiology is more vascular than viral. Then comes the vestibular schwannoma. So vestibular schwannomas, which arise in the myelin sheath of vestibular part of 8th nerve, often cause only vertigo, a tendency to fall, nystagmus if the pontomedullary brainstem and the flocculus are compressed, and increasing peripheral tone difference can no longer be neutralized by central compensation. And the main symptom here is slowly progressive unilateral reduction of hearing without any identifiable otological cause. So along with this is combined with caloric hypoexcitability or non-excitability, and the so on diagnosis you have to do so there is rarely also a loss of hearing as well as recurrent attack of vertigo in cases with purely intracanalicular dilatation, which is confirmed by MRI. And the surgery is basically microsurgery or with gamma knife. So this is about the vestibular neuritis. This is an important topic for your exam. I hope I have covered everything. If I have missed something, please let me know. Now to make this presentation, I have referred Scott Brown, Shambog, Ludman, and Sataloff and Cummings, and Bailey's also. Okay, so these are the books that I have referred, and it is a separate chapter in Scott Brown, so you can refer Scott Brown, and whatever additional points are there you can take from you can mark in Scott Brown itself. Okay, so thanks a lot.